We have the insight of our good friend Dr. Will Lee to thank for curating that meal. Dr. Lee had to stay in Boston. He was scheduled to speak at this conference. He had to stay in Boston, and his presence and his wisdom are sorely missed, and we send him our warmest good thoughts. But we have him to thank for that delicious meal. One of the most significant challenges that we face today is a society-wide crisis of confidence and loss of trust in the authority of institutions generally. Where medicine is concerned, despite great advances in treatment and care, trust is lacking. This panel will address the root causes of that problem. Oftentimes, physicians do not have enough time to establish relationships of trust with patients. Other times, direct-to-consumer advertising blurs lines between patients and customers. To lead this panel, please welcome Dr. Edward Kim, the Physician-in-Chief of City of Hope Orange County and Vice Physician-in-Chief of City of Hope National Medical Center, and an all-around great human being. Dr. Kim.
Well, this is a really important topic, and I thank you all for making time today to come hear this discussion. We've got two really great panelists up here. I'll have them introduce each other first, because I already got a nice welcome from Jim. So, Dr. Chehabi, we'll start with you.
Thank you very much. I'm Hazem Chehabi. I'm a nuclear medicine physician, so my perspective today will be in line of my experience with my patients in the practice. And before I start, Ed, I want to thank you for including me in this prestigious presentation, prestigious conference. I'm very happy to be here. Thank you.
Thank you. All right, Sanjay.
Yeah. My name is Sanjay Juneja. I'm extraordinarily humbled to be here and learn from you all and just be so inspired, really, for the collective mission that we have. I'm a medical oncologist, my wife and I both, actually, in southern Louisiana, and very serendipitously kind of recognized, especially in the South, how perhaps distant the understanding of cancer was when it came to how to treat it, as well as the reasons we, did the things we did. That led to basically me starting to educate on social media, which led to an audience of 1 million plus that kind of now are very interested in hearing about how cancer therapy works and the whys and the things that don't make sense, but primarily to combat a lot of the misinformation that's out there, and it's led to a podcast. I've been humbled to have, Keith Flaherty, Sid Mukherjee, Greg Simon, all in the interest of really talking about some of these challenges, and that's why I'm, again, just humbled to be here and to share those, insights.
So this topic has really come up most recently because of the pandemic, and it is one of really an urgent nature. But I'm actually going to start with a few slides. I know that's a little bit different than what we're used to. Don't worry, I've only got about 60 of them, so just sit tight, and I'm going to walk you through each one of them. But if I could have the first slide. I borrowed this one from Dr. Lee, Richard Lee, and he is in charge of our Turing Family Center for Integrative Oncology. And he shows this because many people view integrative oncology as other things like alternative medicine and other things. So we know that there's already some inherent mistrust about some of the even therapies we hear about. And I just thought it was a nice segue on how we're going to get our information and how you all as consumers of information go. Can I have the next slide? But this really hasn't been a recent problem. We know that there has been inherent trust in the past from different experiments in different groups, and that we've gotten over a lot of that. But, I'm showing you now some very seminal publications in some very prominent journals by prominent scientists. And if any of you lived through the 80s and 90s, you know that bone marrow transplant was recommended for people with certain solid tumors, including breast cancer. I was in medical school and had a friend whose mother went through that, actually. Luckily, she's fine. But we knew later, as we validated this, it wasn't true. Next slide. And so, again, as we finally saw that, we saw that there was not improved survival. And we had multiple studies that were to validate this. And so I think the example here is that science is a continuum of data. It's not a single point in data. Next slide. Also highlighting certain discriminatory practices that occur. We're still having this debate of how we calculate kidney function among certain ethnic groups. And this can be very troubling, especially when these types of factors are included in our clinical trial eligibility. And so what data who we study, what data we gather is coming from not the holistic population, but excluding members of our society that perhaps should be included more. Next. And again, being a lung cancer oncologist, I still remember when this seminal publication changed the standard of care, and we started looking at things saying, gosh, can we change genomics, use genomics to dictate whether we get adjuvant chemotherapy? Next slide. And mutation rates in certain ethnic groups. As you can see, I highlighted two of the columns. These were small numbers. We didn't know how to detect mutations early on. It was small numbers. And we even had prevailing theories that African Americans or people of Latino descent didn't have EGFR mutations, so we shouldn't test them based on these small studies. We now have learned that, in fact, those populations may have a slightly higher incidence of mutations, which changes your entire perspective on treatment of whether you're offering a pill and living years versus chemotherapy and living months. Next slide. And so we know that certain things definitely are driving this. And we know that there's even what's called an absolute neutrophil count. This is another eligibility criteria in clinical trials that is used to exclude populations. And we know that about a third of the population in African Americans have this antigen on their red blood cells and ANC, and it will decrease their levels. They're normal levels. It's just a baseline. Next. So again, we need to really think about how we're listing our criteria for eligibility in clinical trials. Only 1 out of 20 people with cancer qualify for clinical trials in this country. And we are artificially putting up that barrier. So the trust issue has been growing over the decades. This is not a recent COVID phenomena. It's just become in the news more recently. Next. And so, there are multiple aspects that are there. One of the slides I had in there was not science. It was actually, is Pluto a planet? Can anybody tell me if it's a planet or not? So no. Any yeses? It's okay. Be brave. Speak up. Well, and we have a fondness for it. But actually, what's happened is that the state of Arizona in 2024, where Pluto was first described, passed a state resolution where it, in fact, is a real planet. So, and we think, well, it's a dwarf planet? There have been arguments that it's because the Europeans are developing the criteria around what constitutes the criteria of a planet, and therefore it means that it didn't fit all three criterias of things orbiting and whether it's round. I can't make this stuff up for you. So it begs to tell you, do we even know today, is Pluto a planet? In the state of Arizona, it darn well is. The rest of the country, maybe not, but who knows what will happen. So these are the things I sort of set the tone with as we talk about trust. And I'm going to start first, Sanjay. What is trust? I mean, we can't even decide if Pluto's a planet or not. And if I were giving this talk in Arizona, it would be the opposite. Everyone would say, yes, it is a planet. We found it. We discovered it. Your thoughts?
Yeah, so, it's a great question. It poses consideration. I think even before really saying what is true and not true as the root word of trust, I think trust first is earned with honesty and transparency and ownership, both of fallibility and of the things that you're trying to accomplish. And I think there's this cultural kind of maybe mindset that perhaps medicine at one point was more patriarchal or matriarchal and this is what we do and this is how we do it, and not so much this is science, this is theory, this is the practice of medicine. And I think we've done much better with that. And so the reason I say that and what I'm alluding to is ever since, especially I believe, social media, has become by far the number one place for consumption of news and information, you have this kind of consolidated, like a pressure cooker of all of a sudden the things that we know internally that we don't get right all the time, transplants with breast cancer, teratogenic, tetracycline stuff, which was horrible. And you'll hear every now and then, oh, doctors used to say smoking was good for sore throat. So you had all these little things. Internally, we know that we've always, gotten things right and wrong. But all of a sudden, they're all being kind of called out. And people trust when they have information and explanation. And I think that's what's turning now, is to say the whys for the whats. And I think that's what builds. A funny story is when I would go to the auto shop at first, and they would tell me what that estimate would do. I'm going to do this, and I'm like, well, why are you telling me all this? Like, I don't know anything what this means in my head. But then when I go to an auto place and they say, well, it'll be $3,000, and they don't tell me, like, all of a sudden I'm like, well, what are you going to do? What is it you're doing? Not that I know, but it was the difference of the explanation that, in a weird way, builds trust. And for many reasons, it's challenging to do that in today's practice, given the deficiencies.
Both of you are frontline providers. Hazem, you're a radiologist. I mean, you would think, hey, there's only a truth. It's in the scan right in front of you. But explain that dilemma you have, and patients, when they hear results, they would think it's clearly black and white in front of them.
So patients come to us with some level of information. It could be rudimentary, it could be sophisticated, but it's information. Some obtain it through visiting some reputable sites, and some get their information from TikTok videos. When I meet with my patients, I listen. I'm never dismissive. I'm never judgmental. I listen and I try to answer questions, and I try to provide evidence-based facts to guide the management of those patients. As a nuclear medicine physician, radiologist, I sit in a dark room looking at a monitor all day long, and I'm looking for bad stuff. And I find bad stuff. And knowing what I know where perhaps the beginning point is and where the end point is. And I visit with those patients, and I give them the truth. I give them the facts. Patients often come to us, and I ask every patient who wishes to go over the study with me. I take my time and I sit with them, and I start by asking, do you know why you're here? And the answer is often, well, because my doctor sent me. Well, do you know what the study we're doing is really meant for? No, my doctor said I needed it. So I start by explaining the clinical question we're trying to answer. And I go over the findings, and whether it's a question of confirming a diagnosis, ruling out a diagnosis, staging, upstaging, downstaging, assessing response to treatment. These are all questions that are extremely important for the management of this patient and for the patient's family to understand and learn. So I do take my time and I present facts honestly. I don't take anything for granted. I allow them the time they need. And they leave often with a CD containing the images and the report that went out within hours of completing the examination. With the development and evolvement of theranostics, we now have a therapy component that has significantly increased over the last few years. So I find myself now playing the role of a clinician. I have to see those patients who are referred to us for whether it's prostate cancer, whether it's neuroendocrine tumors. Those patients need to be seen clinically. They need blood work that I order and I review and I manage, and I participate hand in hand with our colleagues in the medical oncology field. So to build the trust, to build that level of confidence, it really starts with the face-to-face meeting and the time you dedicate and allocate to that encounter. And it's good to learn that with AI and what AI can promise in terms of delegating some of the other duties that are not necessarily clinical, documenting and otherwise, that we as physicians, we will have more time to spend face-to-face with our patients, giving them the time they need, the care they need, and the attention they need. I think that will only help build and develop that trust further.
You know, we're going to get into that time aspect of it. Trust is a very nebulous aspect, and we're all providers here, so I'm going to ask you this question, and I'll even answer as well. We try to work in the healthcare profession through an altruistic lens, trying to do no harm, try to help people, give them the best we can. The intent is there. We've all had this happen, where whether it's a patient or a family member who doesn't believe what you're saying. You're saying it with best intent, you believe is the right thing, it's what you would recommend your mother or your sister or your friend to be, but they don't believe you. Can you share an experience and how you navigated that, how that made you feel? So, Sanjay?
Yeah, and it happens often, and it's very challenging. You know, one example that kind of immediately comes to mind is always that news when you're delivering to a stage 2 or a stage 3 patient, you know, that this, and you gave, you know, adjuvant chemotherapy, so they went through it, and say the spouse was just already opposed to this. Well, the surgeon said they got it all, right? Because the surgeon always gets it all, choking. But like they do, they get every gross amount of gross disease. And then they were very reluctant on the chemo. And then you do the chemo, and, you know, hopefully they didn't get sick or admitted with neutropenic fever and stuff, but you're already off to a bad foot. And then it comes back 6 months later. And then it's like, we did this chemo, we did this whatever, and now your trust is truly fractured. But the way I, you know, do my best to get around that, and that's, you know, I think why we owe the education piece, is then explaining that, like, the scans were clear, what happened, you know, and it's, when you explain that a 1 centimeter tumor on a CAT scan is 1 billion cells, and that, you know, at best, maybe you could see on an average CT scan a 0.5 centimeter, which is 500 million cells. That's why the scans were clear, because 50,000, 100,000, 1 million is going to take a significant amount of time, depending on the replication rate. So pancreatic is fast, it's going to show up faster. Hormone-positive breast cancer is much slower, and it's not going to shed. That's why the circulating tumor DNA is negative. It's those kind of things that can at least offer some kind of explanation on why this spot is in the liver now, after this breast cancer patient lost all of their hair, got very sick, for 4 to 6 cycles, enters in your office a year later. And, you know, that explanation, you think there's time in our clinic of 20 to 25 patients a day, like, and always being behind, get them into the treatment because it's 5 hours, because chemo, you know, treatment room needs to go home, and there isn't time for it. And so now there's this leap of faith that's very impositional, to where the spouses and the family members, oftentimes of the patient that will be sometimes lost, will always for the rest of their life have the debility of, should I have gone holistic? Should we have done the vitamin C? You know, I believe in a lot of these things for, like, you know, adjunctive investigation, et cetera. But you're plaguing the family now, because you never really explained why, and the outcome was still not what you were seeking. And I, you know, you incur moral injury. I'm obsessed with this concept of moral injury. There's a lot of that incurred that you just have to stomach and just be okay with it. But I think there are downstream consequences of that. So it's a challenge.
Hazem?
Ed, I want to go back to a principle that was drilled in our minds from the very beginning, which is the principle of first do no harm. Is it really true? Do we always, we strive, but we often do subject those patients to some degree of harm. Chemotherapy is fraught with harm and some side effects and issues that the patients have to deal with, and their families too. So it's important, in my opinion, for us to have a good understanding of how far this patient is willing to go. What their families, what are they willing to accept in terms of the side effects and in terms of the harm, before we subject them and push them into a course of treatment that we know is not going to be benign. You hope for a good outcome. But I find that there's always harm involved. And as much as we try to stick to the notion of first do no harm, without us risking some degree of harm, we're never going to reach our goals.
Yeah,
Be honest with the patient.
I think that measuring of expectations is what you're talking about. I myself have been placed in this situation. I still distinctly remember a patient who had metastatic breast cancer for 15 plus years and had survived that, but what was really debilitating was the chronic pain. She had bone disease, and we couldn't stop the pain. And so she's in constant pain, 24/7, 365. And her mistrust of many oncologists and many pain specialists who she saw, we couldn't get rid of it. And I remember she was admitted to the hospital, and I was explaining to her, we're going to try this and this, and she actually said, she said, I bet you could sell cars, And I said, well, that doesn't sound so bad right now. But, I remember that. And you don't know. You feel very helpless. That moral injury you talk about, Sanjay, is absolutely right. You're trying to recommend what you think is the best, what we would do today to help that person. But they've been through it. They're living it, and that's what's very tough. And so to regain that trust, to build that trust is very challenging. Now, both of you have mentioned time. Needless to say, when we looked at depictions of physicians, when kids are playing, it was a stethoscope and a little plastic bag. Now it's a computer where you sit in front. That is the new life of a physician or staff. How are we going to gain time with patients to enhance and structure that trust, especially in the age where our pressures now are documentation, billing, overriding insurance, and then seeing the patient and talking to their family who have undoubtedly seen somebody and coming now seeing you for another opinion. So, Hazem?
Well, I mean, we're no strangers to staying late at night in the office to finish up the documentation and finalizing reports and things of that nature. You have to find the time for the patient. To me, there's nothing better than that face time that you spend with the patient to build the relationship and to build the trust, to take the time to answer their questions. I offer all patients that come do my practice the opportunity to sit down with me to review their images. And I plan that into my day, even if that means I won't get home until 8:30 at night. And there are many weekends I'd have to go to the office to catch up on things. And so I think it just goes with the mission. It goes with the territory. It goes with what we've chosen as a calling. The calling of medicine, in my opinion, there's no higher calling, and it's the price we pay, and we pay day in, day out, and gladly.
Sanjay?
I mean, same exact thing. There's no alternative. I'll tell you that spent probably the better part of the last 5 or 6 years, my wife and I have it's like rush home, do everything with the kids, and because we will always opt to speak with our patients and talk and help, hold their hand physically and figuratively, our time together is the 8:30 a.m. laptops open, maybe Netflix if we're not too stressed, and it's just literally type notes till you fall asleep with it in your lap at midnight. And that's every single night. And missing soccer games, missing everything because there's just too much need, in this country, especially in the community setting, to where we'll see less patients. Well, then the new patient that we heard about, earlier, this is going now on 5 or 6 weeks before getting to see someone rather than 4. So, that's a whole. I do think one thing that could help is we do say a lot of the same things over and over. So I like to explain how myeloma works. I like to explain how microscopic disease works, tumor evolution, these things that can kind of anticipate when something bad happens. I think that can preserve trust to a degree because you're actually able to, empirically or at least preventatively discuss why this could be a problem. I think those evergreen content pieces can be structured such that you kind of select them and then the patient hears from you if you're comfortable in front of a camera, blah, blah, blah. But at least it's coming from you, and now you can have a higher concentrated time period of hearing about their side effects, explaining this, that, and the other. So there's little things you could do like that, but there's no slowing down. AI actually can help create your prior auths now. That would be the combating from the earlier talk. That's how you reflex it. You make sure that your AI, now these ambient listenings can actually generate the prior auth and all this stuff. So there's these things, but right now there's no immediate solution.
Yeah, I have found that as you go progressively during the day, you spend the first 5 minutes apologizing why you're late and explaining why you're late, and that takes away more time, and it just sort of snowballs on top of it. So we've been there. So I'm going to ask one question and then a follow-up. What is the highest number of references or resources that a patient or a family member has brought into the office to present to you at a visit? And the second question is going to be, where do you get your information? How do you stay up to date? So, Hazem, we'll go with you.
I see that frequently with my thyroid cancer patients. Those patients who come to us following a thyroidectomy, and you work them up and you determine that there's residual thyroid tissue, and whether to proceed with treating such patients or whether to observe, obviously based on multiple factors. Such patients come to you with information they obtained, and there's a lot of misinformation online about the risk of radiation and about the risk of undergoing radioiodine therapy, something that I explained we've been utilizing since around World War II or so with excellent outcome. They bring anecdotes, they bring references they found on social media, they bring examples of something they were told while they were on a trip across the Mexican border. And again, you have to be patient and you have to listen and not be judgmental and not be dismissive and present the facts and hope that you will land on the right page for this patient and proceed with the treatment when appropriate.
Sanjay?
Yeah, so we already said, we already talked about trust building is spending the time face to face, like in a humane way. We said that, giving the respect of education and explaining why we're doing what we're doing, not hopefully just the data, but how it works and why you're going to be sick. And now we're talking about, which I think is important, not rejecting concerns and especially the caretakers' deep desire to do the most they can for their loved one. Like when you don't, I don't want to say entertain, but don't take a look at these things, I think that injures trust. And so I always encourage it. Like I'm like, when I see that feeble, piece of paper come out of the person, I'm like, good, like let's talk about it because that fosters trust as well. And then it's a double-edged sword because it's flattering because to answer your question, I had one that was 43 line items at the end of a long visit that ran over, and they were just blowing up my phone. We got to get them in a treatment room, you're 4 behind. And it's 43 different pieces, NAD+, glutathione, and like all this stuff I don't know about, milk thistle, blah, blah, blah. And I couldn't write it off. I didn't want to write it off immediately. And it's a double-edged sword because they trust me so much. They're like, we don't want to do anything without asking you, but this is all the research and all the subtext behind it. And so obviously, in Baton Rouge, I can't just like send them to, a specialist, this, that, and the other. And I say, well, let me look at this and let's talk about this next visit, blah, blah. But these are the things, and one, you also get moral injury. Like all of these things are moral injury, right? If you're not able to speak on it. But they're necessary, they build trust, and I had a different point that'll come to me later.
Yeah, you guys didn't give me like quantitative numbers, but I'll give you a pass on that. But I remember one patient and their family specifically. We were sitting, and on the floor when I walked in were 4 piles of paper. I felt very bad for all the trees that were down there. And literally, they were about 1 foot high each. And they said, we're here to talk with you. And I was like, whoa, okay. And we just started going through each pile. And some of it I just, put off the side. Some of it I said, this is good, this is not good. Because, again, you're hearing opinions. If we keep the patient at the center of everything that we're trying to do, we're trying to reassure them. And if I dismissed all of it, just as you all have said, that would have just violated the trust, that sort of unwritten code between a patient and the trust of their provider. So I get it, I hear it, and we're going to get to solutions. So talking about communication and hearing what was really being said. I don't know if any of you have seen the Pew Research Center poll that was done last fall. It was done in October for about a week, so it was pre-election. It was about 10,000 US adults, and the title of the poll was Public Trust in Scientists and Views on Their Role in Policymaking. Now, I'm not going to share the data with the policymaking stuff, that's for another time. But the first part, the trust in scientists, was very fascinating. I will say, reassuredly, it was done by phone call or online. 76%, the majority of Americans, have great deal or fair amount of confidence in scientists to act in the best interest of the public. So, good. All right, check. It was higher this year, but still lower than pre-pandemic. Okay? That's one fact. 89% describe their scientists and providers as intelligent. So, okay, all right, we got that part. We go down now. 65% was the next one, and that was the confidence in focused on solving real-world problems and honesty. So we've dropped to about a D, you know. That's an Asian F, by the way, but that's a D. Actually, it's more like an 89% is an Asian F, but I didn't start there. 45% was they described research scientists as good communicators. So we didn't actually make the 50 percentile there. Another data was 49% was socially awkward, okay. 47% feel superior to others. 34% cold, 28% closed-minded. I would not even want a quarter of our folks to feel that perception, but 45% good communicators. 45%. That's not graded on a curve either. So this is real data from 10,000 US adults who are used to doing polls and such. So what are our solutions going forward? How do you get your information, and how are we going to advise the public? Do they go to the peer-reviewed journals? I don't think any of us look at textbooks anymore. I know my daughter is a medical student right now. They don't use textbooks. You're not buying textbooks now. They're going online to find their resources and their information. How do you all do it? How do we now move forward with finding solutions for our patients, their families, and getting this information? Sanjay.
Yeah, so it's a challenge, and I think it's been brutally made more urgent because of social media, because everyone on social media now, it is truly completely unfiltered, like journalism or pseudo-journalism without the same, integrity and of true journalism and thought of consequence, to where a lot of the information they're getting, I always say this when I'm speaking on this stuff, is like there's some nugget of truth in what this thing is that's becoming problematic or distressing for the family. There's some nugget there, whether it's in rat models, whether it's in vivo, whatever the case may be. An example I use sometimes is if you were to graph the number of humans that died in a shark attack against, and you do it over a year, against a combination of when glucose, lactose, and cocoa were consumed the most, you would see that spikes up and is almost superimposed, those two graphs. And so you may say, that's crazy. Is that because they appear sweeter or maybe more delicacy because of their lactose stuff to sharks? But the truth is, it's because ice cream consumption increases in the summer, and it seems very correlative with when people visit the beach. So in the winter months, you don't have many shark attacks, and then you have all this, and they're superimposed. But again, it's just because ice cream is all summer activities. Now, you're having a litany of people on social media do that about every single solitary thing you could imagine. Chemo's a poison, and all this stuff, and you have to, again, I had to meet it with validation. I'm like, yes, it is a poison. But I can also argue when it's saying, you need natural treatments. I'm like, well, Taxols and all these things are, made from plants and urchins. So you accept and then you explain. But remember, cancer cells are unregulated cell growth. That's literally what it means, and it's your own cell. So how can you kill something that is yourself with your DNA that, and somehow just select for it by eating something else, right? And then you get the idea of, okay, replication. If it's really fast, that's what I'm attacking. Hair cells replicate fast, so does the gut. That's why I get nauseous and lose hair. Now you're earning trust because it's starting to say, like, you're acknowledging that it's a poison, that people get nauseous and lose hair, but you're explaining to me because it's, it has the same, biology as the rest of the body. I can see the challenge, etc. So One, I think we do need, whether right or wrong, right or not, we do need to provide information when there's a ton of information against what traditional medicine is doing. And two, just making a real insult to data with some of these, that ice cream example I gave you. But yeah, I think it's going to be multifactorial. I think we need to warm up to the idea of evergreen explanations and solutions, whether we're doing it ourselves or bringing it into our institutions. It sets, people need to hear something a couple of times, right? Like the number of times I get called by the ER and they're like, yeah, they seem to not know anything going on with their cancer. I mean, I take personal offense. I'm like, trust me, my patients know. But it's the setting, and it's the fact that someone is sick and they don't want to not get aggressive care knowing they're stage 4. I mean, it's just so insensitive. Like, of course the family's going to say, the point is, I think it's multifactorial, and I think we're going to have to either find a solution to have more time with patients or leverage the ability to educate outside of the office, possibly through content, to be able to try to account for it.
Hazem, where are you going to tell patients to get their information? How do we do that?
Those were ugly statistics, Ed. I might as well just dismiss them. No, we're not going to do that. I mean, certainly with what social media has done in terms of disseminating poor information, bad information, and with what the world went through with the COVID pandemic, the trust of patients has certainly been shaken with our providers, with our healthcare institutions. So there is a ton of work to be done. In terms of where to direct patients, to me, it boils down to education. It boils down to what we do day to day with the patients that we see, and with what some of the activities that institutions like the City of Hope, like UC Irvine, what they do in terms of reaching out to the providers in the community, to the patients at large, educational meetings, sponsoring events, focusing on prevention, focusing on early detection of disease, and providing those resources. I think this is one way, perhaps, where we can regain the trust.
Yeah, the hard part is the filtering of information, right? Where would we instruct anyone today to go to get their information, right? I don't know if we'd have a straight answer behind that. And we know there's different types of information. There's the textbooks, which for many of us who have written textbooks, you publish them 3 years later. Not very helpful in a field like oncology or others. There is meetings ongoing across the country, and sometimes those meeting abstracts have groundbreaking research, and that hits the news and the media very quickly, but sometimes it's not published yet in a peer-reviewed journal. So you hear something at a meeting, is that what you go home and practice to, or you have to find what the truth is and whether they're validated or not? That's where I struggle. If someone asked me, where would you go for a reliable source of information, I don't know if I'd have a straight answer. I'd say we have to rely on many people, and getting a couple opinions is always, I think, reassuring to people. But I don't know how you instruct that. Hazem, how do you instruct that to folks?
It's not easy. It really isn't easy. You have to be knowledgeable and aware of the best resources to provide those patients. And that's a chore by itself. I mean, we have a pretty good idea of, whether it's UpToDate or WebMD or some of the other sites that we go to. But as far as the average patient is concerned, I would encourage them to reach out to their providers, to reach out to their physicians, and seek perhaps guidance and seek some sense of direction. The conferences are great, the meetings are great, community events are great. Perhaps we can participate and be present at our local libraries. They host events on a regular basis and talk about things that are relevant to the patient population at large. But it's not an easy problem to tackle, but it's not impossible.
And Sanjay, as someone who, I'm just guessing, a little younger than the two of us up here, but one who has been more with the social media and in tune with it, and I live it vicariously through my daughter. You heard a lot when I mentioned TikTok before and others, and there's a sort of a brushing off of these social media streams is actually providing true education and teaching. But I can tell you, living through my daughter, these young folks get a lot of instruction and a lot of information off of these social media channels. How to cook, how to clean, well, not so much cleaning, but how to put on makeup, how to do other things, and they become reliable, consistent sources through these influencers, and that builds the trust. Your viewpoint on medical information through some of these, I know there's a ton of doctors out there doing this, the usefulness and the dangers of social media.
I mean, look, I think overall social media is more of not a good thing than a good thing. Like, I feel pretty strongly about that. But it is what it is, and it's out there. And the numbers reflect that. I mean, if you were to look what the consumption of social media content is between YouTube, TikTok, and Instagram, it completely destroys anything when it comes to news, journals, reading. I mean, nothing even comes close. And it's no longer younger people anymore. Especially when I put breast cancer content, if it has 1 million views or whatever, if you look at the number one demographic, it's 55 to 60 of that million accounts were 55 to 60 years old. The next one is 50 to 55 and 45 to 50. So it is consumed everywhere, for better or for worse. It's just too easy to make good content or appealing content on the easy answers, of just saying this is the miracle drug, this is the miracle cure, and it is heavily problematic. Now, I'll tell you, I think where education can really be improved on, to talk about the challenge, is truly generative AI. I'm just curious, has anyone never used ChatGPT or Perplexity or, okay.
I just did it a few months ago, so I'm with some of you here.
So if you go to chat.com, I like perplexity.ai. They call it this fancy thing called prompt engineering. All prompt engineering means is really describe the context on what you're asking and why. And if you go there and you say, tell me why do we use chemotherapy after the surgery has already occurred for a cancer that has not spread? And talk to me like I'm a non-medical individual that is very attuned to, automotive mechanics, and use only analogies in this capacity, and tell me what the data shows in a stage 3 breast cancer. You will be mind blown in 3 seconds on how well it has explained why we do chemotherapy, how it works, why you have the side effects, and will only use stuff that you will understand on how the machinery works of a vehicle. That is what's so unbelievably incredible. Now, is it going to be the ultimate answer and the trust issues? Yes, those are all concerns. But prior to today, there was no even remote easy way for a non-medical person to even start the process of making sense of these things. And if you do that, you can really start to appreciate possibly the burden or the labor of that can at least hack away the overbrush, and that way you can start pruning the garden, so to speak, within the clinic room and start talking about the details. But I think it has tremendous potential in that capacity.
Is the solution moving forward that maybe the AMA or ASCO or the NIH need to have our own social media channel with our groups of scientists and others to start putting that information out there? I know it's usually CME and other seminars, but is that something, Hazem?
I would think that it would be something, and it would be a step in the right direction. I wonder if AI could be used to filter through all this information that's out on social media to direct the consumer toward what is believed to be legitimate and to be true and to be evidence-based. I don't know, Sanjay,
I mean, Meta just took it away. So they used to do that. They used to screen, like on Facebook and Instagram, stuff that was potentially false and stuff. And then they went under a lot of derision because it had a political agenda. So now they removed it all. So I think it's some time before we'll see that kind of invasiveness, to the whole concept of freedom of speech. it's a hard battle, and it's a concerning one. But the timing, at least with AI, I hope, and that's why I've studied it so heavily the last year or two. I think it is something that can truly nullify the growing concerns of what we all know is just consumable content that's not, that's very, it fractures the trust in what we're saying, and not having the time or the means to be able to combat it has been a big problem. And fortunately, in a weird way, generative AI is here to hopefully reorient and kind of bring down some of the stuff you're finding, quote unquote, on your own.
I sat on a committee a couple years ago with a large cancer organization, and it was a trust in science committee. And we put our brains together to try and figure out how we can start rebuilding the trust. And one of the proposals was a bidirectional communication platform that, again, needed to be filtered, needed to be with a group of folks. It's an idea that we're moving forward with. However, scaling that becomes challenging. And you can almost imagine the number of people that will want to get replies. We already know that in our own institutions, when people call and leave a message or use the chat function, they want answers quickly. And I doubt we're all 24/7 to get those promptly back. I mean, these folks have medical conditions that require urgency. Is that something that could be feasible in a bidirectional manner? And how much time would that take? And who would do it in almost a peer-reviewed process? Hazem?
Sanjay?
I mean, that's one solution, but I think the bigger picture is you keep doing these things, and I think it starts to deviate even further from the core principle. I mean, Google reviews are a very real thing now, and people sometimes, if they go to a second opinion and get told something they wanted to hear, like all of a sudden you're talking about the liability of your professional reputation on making sure to, if it's refilling the meds, or it's unbelievable how much it's already been strained, I think, in some aspect to more of a service industry, which I'm always patient first, like even being on the medical side. Like I think patients are disserviced in several ways. I think the providers are in several ways as well. And I do think the meeting in the middle is, I don't know that it's direct engagement that way. I think that could be problematic. And when you ask yourself, say you needed someone to explain to this person that was challenging, but say that your administrator came and said, I'm going to spin a wheel and it's going to be one of the doctors in your entire institution. If you have a moment where you say, I hope it's not this one or this one or this one, now you can kind of appreciate where this trust issue may happen. If you're actually preferring it falls on somebody, all that's doing to me is just explaining like our own fallibility, our own varying shades and degrees of effectiveness and not, and personalities, which I think we should have the grace to say that's okay. But think of that picture of the wheel spinning and saying, I hope it doesn't land on that person, my facility. Now you see the problem, right? Because that wheel is falling on that for somebody all the time and vice versa, and it doesn't speak anything about how competent or good they are at delivering the care, but how the perception of the reason for that care and that delivery is. Now all of a sudden we're talking about the perceptions that are leading management, and I think that scientifically is a big concern.
And I remember years ago, I served on the Medical Board of California, and I was in charge of the Medical Quality Division, where physicians would come in front of the board for disciplinary actions. And we would see obviously some of the best of what our profession can do day in, day out, but also some of the worst that our profession can engage in. And often we would impose disciplinary actions on those physicians, and one of the things that would be considered is an ethics course. And the question has always been to me, how do you teach someone ethics? How do you teach a 50-year-old or a 50, 60-year-old ethics when they've not been inculcated into this from their very beginning? And to me, the issue of trust is very close to the issue of ethics. You either have the ability to engage ethically and truthfully with your patients, or you don't, but it's something we have to work on, I would say, day in, day out.
I want to always redirect this back to the patient, right? Because patient outcomes are truly what we care about the most, and we want better outcomes there. We used to be in a society, a communication society, where you had one physician. It was a very paternalistic and maternalistic relationship, and that was the one person you did. I grew up in a small town in Indiana. We trusted our family physician down the street and didn't know what was happening in Chicago, Indianapolis, or St. Louis. And that was the level of trust we had, and we did anything that we were told. Now, fast forward to today. Information is freely available for all parts of the world. We know that the families, the patients, access to information is huge. They can go find it and such. 10,000-foot view, we've discussed a lot of the nuances of the dangers, the pitfalls, the benefits. Do we think having all this access to information, good and not so good, is leading to better outcomes for patients? An informed public, an informed patient, again, misinformed depending on what you read, but do we think it's leading to better outcomes? Is it placing a better check and balance among providers, knowing that that's out there and people can find it? Sanjay?
So, at least as it relates to consumption on social media, which again is by far the number one place that apparently people are finding healthcare information, including actually providers as well on some recent studies. I don't think it's necessarily leading to better care. Of course, I say that, and then at the same time, I'm putting out content until I recognize the value of AI. I put out content because I noticed the care was there, the inequity was crazy, like in general America. Like anemia is never getting fixed. Them, living at 8s and 9s and never getting IV iron or iron checked. People not getting molecular testing still. So as y'all heard earlier, the example from Sean about 40%, 30% chemo response, but now we have targeted therapy. There's still 10% of people that don't get even the molecular testing for that targeted therapy today. Like 10%, 1 out of 10. And so I was putting out education to say, if you have stage 4 cancer, I hope that you're getting your molecular testing. If you're Latino or African American, it goes up to 15%. So in those capacities, that was the entire purpose. If you're HER2 positive, especially younger, stage 3 is neoadjuvant. A lot of people are getting upfront resection, and they have a higher chance of dying from this now. This is still today. We see all this literature everywhere. So how do you get it out there? That in that way it can be valuable, but unfortunately, it is very disproportionate on the amount of stuff that is trying to direct, which mine has always just been an obligation. It's not something I enjoy really anymore and haven't for a long time, but it's obligatory because they deserve to get something that counterbalances the litany of very concerning information. And if nothing else, it just casts doubt now on the decisions that were made to keep mom around, your wife, your husband, and your children. That's forever. Because that one video you saw, you're like, did we mess up going to an academic center or going to traditional medicine? And that's so tragic and sad. So I think overall, it strained the sense of the bigger picture, which is now patients have to make the first decision, do I trust traditional medicine or not? And I think COVID didn't surprise us. I think as a medical community, I'm just going to say this, I'm proud with the mRNA, aspect and everything. I'm very proud of what it showed. But on another lens, it showed, medical fallibility or human fallibility of medicine to a way that's really made people cast doubt on that Indiana physician that you just went to and all of a sudden you're rethinking. And so I think it's just sad more than anything that decision has to be made first. And then when you take that decision, do you keep it? Do you go this other route? I think it's challenging, but hopefully AI is literally here right at the same time to be able to help navigate that a little better.
Hazem?
The dissemination of widespread information is a double-edged sword. Obviously, there's some good and there's some bad, and so to go back to what you said earlier about checks and balances, there has to be some level of checks and balances to make sure that the information out there it does not cause harm, does not injure the patient rather than help.
Yeah, and I'll just share my own viewpoint. I always believe having more information is good, but just as you two have already articulated, sometimes we're not sure what to do with the information. We're not sure how to weigh what is a higher weight versus lower weight information. And so I feel a lot of times people look for information to answer the question they're looking for, and not necessarily looking at it holistically as balanced. And I think that's where the internal biases come in. If you have heard stories about chemotherapy and you just don't want to do it, you're going to find ways that you can't. And those are people who seek therapies. And I think it's trying to rebuild the trust, but we also can't convince people. I've seen too many times when children, adult children, bring their parents in and say, we want you to be treated. And parents are like, nope, not going to do it, not going to do it. And I've told the kids this. I said, it doesn't matter what you say. They're the ones going through it. They have made their decision on this. I can talk to them. You can talk to them. We can get Dr. Van Eschenbach to talk to them. It doesn't matter. They have already decided their route. And I think as physicians, we have to accept people's beliefs and wishes, feeling like we've informed them in the best way of doing that. And when we look at quick wins, I'll always go back to this. Clinical trial eligibility. How many people go to academic centers or regional centers looking for that clinical trial? They found it online, they found this drug, and they find out they're not eligible because their creatinine's a little bit off, their liver enzymes are slightly off, their hemoglobin is 7.9, yet they're walking around doing everything. That upsets me, because we are trying to promote science through our clinical trials enrollment. We want to enroll people of all colors, shapes, and sizes into these trials and learn. And when we impede that, that to me is a quick and easy fix to already begin really promoting. And this is something the NCI, the Friends of Cancer Research, ASCO, the FDA have all stood behind and have been supportive about it. We got to get industry. If you're listening out there, industry, please, let's reduce the eligibility criteria, allow more people to participate in these trials so we have that data that is a heterogeneous society that we are, and learn and be able to apply AI to that to make these better informed decisions down the road. That's my plea today. So last couple minutes, we're going to just take a final takeaway thought from each one of you to our audience. We have it online as well as here. What is it you want to transmit to them? So Sanjay, I'll start with you.
Can I bump to you first?
Hazem, he's bumping to you, yes.
By all means. To me, never be afraid to ask your physicians the questions. Insist on FaceTime. Insist on meeting with the physicians. Insist on taking the time you deserve. Ask the questions that you have. Present whatever information you wish to share and to clarify, and hold them, hold their feet to the fire and make sure that they give you the answers you need before you go on to the next decision or to the next step in your care, because it's not always rosy and it's not always easy.
Sanjay?
Yeah, I mean, similarly, I think that's perfect. It's just, I think from the provider side, we all know and at our core believe that patients deserve to be involved and in that car, and the downstream psychological and emotional aspects of that can be so different if you are involved with the stage 4 diagnosis or not, even though it's the same diagnosis. It's happiness and fear the whole time. And on the other aspect, also giving ourselves the grace of realizing that the system is thwarted to a degree in certain aspects, and it is an imperfect system. And so I think if patient population too, and they're starting to on social media, they're starting to become empathy for the healthcare side of things, learning some of these very nuanced strains and technicalities that they're like, oh, I see why I get little time and things like that. So in that way, it's been healthy. I think at the end of the day, Joe, just dissolving these lines of patient, industry, healthcare, et cetera, the more we dissolve those and have this collective mission, I think we would just soften and share empathy easier across lines that hopefully are themselves gone at some point for the collective mission.
Yeah, and I just want to say that we hear you. We are trying to conduct the research, knowing that a standard of care is only a single point in time. Our job is to continue to recreate the new standards of care What we're doing next year will be different from this year, and that's good. That's scientific progress, and so it is this continuum. And so data points are single points, but knowing that things can change, and I think information is empowering to people and their families, and just know that we're going to continue to do better, knowing what the challenges are forward. So I want to thank you both for a really robust discussion, your frank comments, and I want to thank everybody here today for participating, listening in. Thank you very much.
Let's give them a round of applause. Doctors, thank you. Ladies and gentlemen, we'll take another short break, just 15 minutes. Please take this opportunity to do whatever you need to do, but we will come back here and we'll get started on our fourth and final panel, New Ways and Means of Communicating About Cancer, which includes participation from Dr. Kat Arney, who is coming to us live all the way from the United Kingdom. So join us back here in 15 minutes. Thanks.